respiratory system includes your nose, nasal cavity, the sinuses, the pharynx, the larynx, the trachea, the bronchi, the bronchioles, and the alveoli. Okay, in that order as I go down. It gets smaller and smaller tubes. And the reason it gets smaller and smaller is so air exchange, gas exchange can occur from the air you breathe in into the bloodstream. Okay. The upper respiratory system, okay, is your nose, nasal cavity, sinuses, and pharynx. This composes your upper respiratory system. The lower respiratory system is below the pharynx, which is your larynx, your trachea, your bronchi, bronchioles, and alveoli. Alveoli are the smallest or thinnest portion of the lungs where gas exchange occurs from the air you breathe in and the blood vessels. Okay. So here's your division. Okay. Nasal cavity, sphenoides, nasal pharynx, larynx, nose, frontal sinuses, and all your nasal concha, your inferior, your middle, and your superior. This is all your upper respiratory system. Your lower respiratory system is where your trachea, bronchus, bronchioles, and then the alveoli in the lungs. Okay. And again, we talked about this a little bit last time. You see that where this comes down, you see the right bronchial tube is a straight shot. So if something aspirated during surgery, okay, doing whatever you're doing, this is where you look first in the right lung, because you see this is more of a straight shot than the left lung. Function of the respiratory system, what does it do? Okay, it provides an area for gas exchange between the air and the blood. So it allows oxygen to go from the air into the bloodstream and allows carbon dioxide to go from your bloodstream back in the air so you can exhale it. Okay, it protects your respiratory surfaces from dehydration, keeps them moist, provides protection against invading pathogens, okay, produces sound involved in verbal communication, and it assists in the regulation of your blood volume, your blood pressure, and your body fluid pH. Okay, all those are functions of the respiratory system. Okay, the epithelium of the respiratory system, it's pseudostratified, ciliated columnar cells. Okay, ciliated means it has those little hair-like cilia on it. And in the lung tissues, the cilia only beat in one direction. Okay, they beat towards the oral cavity. That way, when mucus is produced, anything gets trapped, pathogens, you're constantly producing mucus in your bronchial tubes. When it traps bacteria or pathogens in that mucus, it forces it back out of your lungs. Okay, it doesn't beat back down deeper into your lungs. So that way pathogens go back out of your lungs. So all these cilia, the pseudostratified ciliate columnar epithelium, okay, it beats towards the oral cavity, away from the alveoli. Okay, you have stratified squamous cells in the pharynx, and you have mucus-producing cells in the nasal cavity and in the lower respiratory tract, again, to trap pathogens so they don't get into the lungs. Okay. The ciliated columnar cells move mucus in an upward manner, like we said, like a mucus escalator, so debris can be coughed out. The stratified squamous cells provide protection against abrasion. That's your stratified means what? Remember, there's simple squamous and simple epithelium and stratified epithelium. What does stratified mean?
Squished out.
That's squamous. Squamous means squished out. So you're right. Squamous means squished, but stratified means
layered.
Layered, 2 or more layers. Simple means 1 layer. Stratified means 2 layers. Squamous, just like Ethan said, means squished out or flat. Okay, helps to protect the area. Okay, so stratified squamous means squished cells, multiple layers for protection against abrasion in that area. Mucus cells produce mucus, so inhaled debris and pathogens get stuck and don't enter your lungs. Okay. Hairs in the nose block some of the inhaled debris, called fibrissae. Nasal cavity produces mucus that traps your inhaled debris, like we said, and sneezing in the nose will remove that debris. Respiratory epithelium with mucus will trap inhaled debris, and when you cough it up from your lungs. So you sneeze it out of your lungs, and you cough it up, sneeze it out of your nose, cough it up from your lungs, any of this trapped debris that you have. The following is the pathway of air as it goes in. Air enters your external nares. That's the opening of the nose there. It passes by the nasal vestibule, which is your opening. Okay. It enters into the nasal cavity. And then air flows around the nasal concha. There's 3 concha. There's an inferior nasal concha, a middle nasal concha, and a superior nasal concha. Okay. Those are your 3 conchas in the nose, in the nasal cavity. Air swirls around them. Debris gets stuck in the mucus, and the air warms or cools depending on the temperature of the air. Okay, that's why if you're snowboarding and it gets cold, if it's cold where you're snowboarding, you breathe through your nose. You don't breathe through your mouth. You do it automatically because the nose warms the air as it comes into the lungs. You don't freeze your lung tissue. If it's very hot, this acts to cool the air. Okay, so it changes the temperature to make it more closer to body temperature before it enters the lungs. And it traps any debris that are stuck in there. Okay. Then air enters your internal nares and into the nasal pharynx. Okay. So here's your external nares. Here's where air enters. Goes to the nasal vestibule, which is the area right behind the nares. Then it swirls around these 3 concha, the superior, the middle, and the inferior concha. It swirls around there, and then it enters back into the nasal cavity. Okay, and this enters your internal nares and into the pharynx. Okay, and you have a nasal pharynx, an oral pharynx, and a laryngeal pharynx for that division. Okay, so the nose consists of your nasal bones, nasal septum, which is your vomer and perpendicular plate of the ethmoid bone. You have cartilage. You have the external nares, the alar cartilage, the dorsum and apex of the nose itself, and the nasal concha, the 3 nasal concha layers. Okay, so here's the apex of the nose, the tip. This is the dorsum of the nose, the back portion. This is your alar cartilage on the side, and this is your lateral nasal cartilage. Okay, and your minor alar cartilage. Okay, and then the external nares, which is the opening of the nose. Okay, once it gets back into the pharynx, like I said, there are 3 divisions of the pharynx: the nasal pharynx, the oral pharynx, and the laryngeal pharynx. Okay, nasal is a nasal passage, oral is the oral cavity, and then the larynx. Okay, in that order. Okay, the pharynx is a connection between the mouth, connects the nose to the mouth and then back to the throat. So the nasal pharynx is the back of the nose area. The oral pharynx is about back of the oral cavity, the mouth. This consists of your pharyngeal arch and your uvula. And the laryngeal pharynx has the entrance to the trachea and esophagus. Okay, so here's the 3 divisions of the pharynx. Here's your nasal pharynx, back behind the nose. Here's your oral pharynx, back behind the oral cavity or the mouth. And here's your laryngeal pharynx, which is your larynx. So there's your 3 divisions. Okay, and the laryngeal pharynx feeds into the 2 tubes, which are your trachea and your esophagus. Trachea is where your air goes down. Esophagus is where your food goes down. Those 2 tubes there. Okay, this is a mid-sagittal section of a cadaver, and you can see, okay, you can see the nasal pharynx right behind the nose, right in here. You see the oral pharynx, which is behind the oral cavity, okay, and you see the laryngeal pharynx, which is right between where the openings of the trachea here and the esophagus. So that's your nasal pharynx, your oral pharynx, and your laryngeal pharynx. It's just a 2 that connects the nose all the way through back into where the trachea and esophagus are. Okay, the larynx. Larynx is a cylinder whose cartilages and walls are stabilized by ligaments or skeletal muscle. So the larynx stays open. Begins at about C3 or C4, ends at about C7 roughly. That's the area of the larynx. Okay. The larynx has thyroid cartilage, cricoid cartilage, and the epiglottis. Okay. Those are just right in the middle. They're not paired. They're not on the right and left sides. They're one cartilage. The thyroid cartilage contains the laryngeal prominence. The cricoid is an unpaired cartilage that sits on the base of the thyroid. And the epiglottis, this covers over the glottis when you swallow food and blocks it so the trachea food cannot pass into the trachea. Okay, so the epiglottis closes over the glottis when you swallow food. So that cannot enter into your trachea. Yeah. Okay, so here's the epiglottis. This is a folded tissue that folds over the glottis and prevents food going into your trachea. Okay. This is your thyroid cartilage. This is your cricoid cartilage. Remember I told you when you're doing a cricoid thyroid membrane puncture, this is where you're going to come in right here, right under the Adam's apple. Okay, that's a cricoid. That's an emergency procedure in a hospital where you open it up if someone's choking or blood loose angina where the tongue swells, they can't breathe. And if that blocks the airway, that's where you take a sharp instrument and poke a hole right there, and the patient can breathe. It's called a cricoid thyroid membrane puncture. Okay? And then the trachea has these little C-shaped rings that make it very unique. These are cartilaginous rings that are across the whole front, but in the back they don't connect. They're just a C shape, but they keep the cartilage open for your airway. They don't allow it to collapse like the esophagus collapses. Okay. You can have paired cartilage in the larynx also, which is laryngeal cartilages. Okay. They play a role in opening and closing the glottis. And this is your adenoid cartilage, your corniculate cartilages, and your cuneiform cartilages. You can see your adenoid cartilages right there on the side. Then your thyroid cartilages and your cricoid cartilage. Okay, this is a corniculate cartilage and the cuneiform cartilage. All those act in opening the glottis and helping protect that opening. So the trachea can stay open or it can stay shut when the glottis closes over it. Okay. Laryngeal ligaments. You can have intrinsic laryngeal ligaments, extrinsic laryngeal ligaments, or you can have vestibular or vocal ligaments. The intrinsic laryngeal ligaments, they bind the laryngeal cartilage together. The extrinsic laryngeal ligaments, they bind the thyroid cartilage to the hyoid bone and the cricoid cartilage. Remember, the hyoid bone is below the mandible. It's one of the only free floating bones in the body. It does not articulate with any other bone. Vestibular or vocal ligaments, they extend between your thyroid cartilage and your adenoids. Okay. Sound is produced by your vocal cords. Okay. Air passes between the vocal cords creates sound that allows you to talk and communicate. The pitch depends on the diameter, the length, and tension that the muscles control in your vocal cords. So children have a slender, short vocal cords, create a very high-pitched sound. At puberty, the vocal cords become thicker and they become longer, and that's when your voice becomes deeper. Okay. Amplification of the sound occurs in the sinus cavities. Okay. That's so when you record your voice, you sound different than when you do in your own head. Okay, when you're talking, you have your sinus cavities, your voice reverberates back through there, and your voice sounds a lot different than it does when someone else is listening to it. So production of definite sounds depends on movement of the lip, the tongues, and the cheek in coordination with moving air past the vocal cords. Okay. So you can see where the glottis is closed or where the glottis is open. Glottis is open, air is allowed to pass into the trachea. Glottis is closed, nothing is allowed to pass into the trachea. And those are your vocal folds for your vocal cords. So the laryngeal muscles, you have intrinsic muscles and extrinsic muscles. Your intrinsic muscles regulate the tension on the vocal cords. They open and close the glottis. Okay, the extracranial muscles position and stabilize the larynx. Now, a lot of people have more control than others on their vocal cords. That's why some singers can sing and it sounds absolutely beautiful, and some people can sing and it sounds absolutely terrible. Okay? It all depends on the control that you have over the tension that you're putting on those vocal cords and how you can regulate that control. Okay, so when you swallow, okay, here's a bolus of food. Okay, the tongue forces that bolus of food into the oral pharynx, okay, back behind the oral cavity. Okay, laryngeal movement folds the epiglottis, so the epiglottis closes. So it stops the bolus from entering into your trachea. Okay, the bolus moves back down through it, past it. The epiglottis opens, so you can breathe again. So when you're swallowing food, you can't breathe. That's why your mother ever tell you not to talk with your mouth full. There's a reason for that. If you try to talk when the food's in your mouth and the laryngeal muscles start moving past it, the trachea is now open for you to talk. And food can go into your trachea, and that's when you start coughing. And that can be a dangerous situation. Okay? So characteristics of the trachea. That's a tube. It's about 11 centimeters long, about 2.5 centimeters in diameter. It bifurcates at the carina into the right and left bronchi right around T5. So here's your trachea coming down, and it bifurcates. It goes to the right side, it goes to the left side. This bifurcation point right there is called your carina. Okay, that's the carina. The carina is where the right and left bronchi form. It's where the trachea bifurcates into the, excuse me, into the right and left bronchi. Okay, and it's roughly at T5. Okay, the trachea contains about 15 to 20 cartilages, those tracheal cartilage we talked about. They're actually C-shaped. They do not form a complete ring. Okay, they only form a C-shape. The posterior portion is open. Okay, now connecting each cartilage is what's called your annular ligaments. Those connect your cartilage. So you have a C-shaped cartilage, a C-shaped cartilage, a C-shaped cartilage, and connecting these is annular ligaments that keep those together. Okay, so here's your larynx and here's your trachea. Each of these here, that is a C-shaped cartilage. And in between each one, those little ligaments are called your annular ligaments. This is the carina right here, which is a bifurcation. This branches into your right bronchi. This branches into your left primary bronchi, which goes towards the lungs. Okay. Oops, I went too far. So the lining of the trachea is respiratory epithelia. You have a lamina propria and a submucosa. Okay, the posterior side of the cartilaginous ring is the trachealis muscle. That's where the ring does not completely close. That's your trachealis muscle. This allows for constriction and dilation of the trachea, okay, where the rings do not meet. So here's your trachea. This is your opening. This is your lumen. This is your respiratory epithelium that surrounds it. And this is a tracheal cartilage. Notice the cartilage goes from here to here to here, and it ends. This area is open. Okay, that's the distal area. The anterior portion is all cartilage. It's open. It's a C shape. It's not closed in the posterior portion. That's where your trachealis muscle is. You have some control of opening, closing of your trachea through that muscle. Okay, remember that cartilage is only C shaped. It does not close in the back. And we talked about the trachea branches at the carina. That's your bifurcation point where the right and left bronchi split from the trachea. Okay. The primary bronchi enter into each lungs. The right primary bronchus is steeper and larger than the left. That's where you look for things. So a person can aspirate for an object into the right lung easier than the left lung. Does that mean you can never enter the left lung? No. Just means odds are, if a patient aspirates something, it's going to go into the right lung. But that's where you start looking. If you don't find it, then you go to the left lung. Okay, and there's your shot. Right into the right lung. Okay. Each primary bronchi enters the lung at a point called the hilum. Remember, the hilum is an entrance point. Okay. Just like it was in the kidney, the liver, and so on. We have the hilum. Hilum is also the point of entrance of and exits of the pulmonary blood vessels. The hilum of the organ is where the blood arteries and veins enter and leave the organ. The combination of the bronchus, the artery, the vein is called the root of the lung. Okay. The right lung on a human has 3 lobes. The left lung on a human has 2 lobes. Right? So on the right side, on the right lung, you have a superior lobe, you have that middle lobe, and an inferior lobe. On the left lung, you only have a superior lobe and an inferior lobe. Okay, both of them have a hilum. Hilum is where your pulmonary artery and pulmonary veins enter and leave, and where your bronchus enters and leaves. That's the hilum. Okay. The part of the lung that sits on the diaphragm is called the base. The part of the lung that sits up between the heart is called the apex. This area between the apex is called, this is your mediastinum. Mediastinal area. Okay, that's between the apex of the 2 lungs. Okay, so looking at it here, you have your apex, you have your base, where it touches the diaphragm. How do you know this is the right lung? Besides, it's saying so right there. Because it has 3 lobes.
Because it has a middle lobe. Yeah.
Perfect. It has a middle lobe, exactly. If you have a middle lobe, now this is only in humans. Okay, if we do the cat dissection, we're not going to dissect, but other dissections in animals, they don't have the same division. In humans, the right lung has 3 lobes, a superior, middle, and an inferior. And the left lung only has 2, a superior and an inferior. Perfect. Okay, and there's your lungs. You can see your middle lobe here. Okay, your inferior lobe and your superior lobe. Here you have a superior lobe and an inferior lobe right down there. Okay, and this is the muscle. You can see this is your diaphragm. Okay, so the part of the lung that sits on your diaphragm, okay, is the base. The part where it peaks up above the heart. Okay, here's your pericardial sac. There's your heart. The heart in between there is your apex. Okay. And the area between that is what's called the mediastinal area. You can see the trachea, which is your tube coming down right here. What's that pointing to?
Nasal conches.
Well, the nasal concha back there, that's your nasal cavity.
Oh,
Once the
okay.
air passes, yeah, nasal conchas, you get your nasal cavity. Okay, above that, you have this little piece of air right there. Okay, that is your sinus, right? That's your sphenoidal sinus. Okay, once it passes the nasal cavity, what's the next area?
Posterior nasal apertures.
Okay, those are your internal nares right there. Remember the external nares where the nosome is right in here, and this is your internal nares right here. It passes down into
Nasopharynx.
okay, nasopharynx because it's behind the nasal cavity. That's your nasopharynx. And then this is the division of the upper and lower respiratory systems. And then this line here is where it passes up into the trachea. That should be your laryngeal. Where's my button there? That's the esophagus you see right there. Esophagus is distal to the trachea. And this points to the bone right here. What bone is that?
Clavicle.
Deltoid.
Mm-hmm. And then your right lung. And where are we at? We have those shows your ribs. And then your left lung. These are what are those little tubes called there?
Bronchioles.
Bronchioles. Oh, there's your diaphragm muscle. Okay. Then your bronchioles. And then what are these little rings called? Is that what it's pointing to? Or what's this branch? What's this called right here? This tube.
The right,
It's like bronchial.
Yeah.
Right, primary bronchi, right? Or the bronchus. It's in the primary bronchi. And what is this tube here?
trachea,
That's your trachea. Okay. And this one's pointing to
larynx,
that little flap, I think, that closes over the trachea. What closes over your trachea?
glottis,
Oh, it's the larynx. Never mind. It's pointing to, it's this area right here. That's the larynx. That's pointing to. And that right there is the,
Hyoid.
looks like the hyoid bone cross section of it. Yep. And then this is your what?
tongue,
Your tongue. And this bone here,
Your nasal bone or your nose or something.
nose and the nasal bone. And now we got the, what are these three things called here?
nasal conchas,
Nasal concha. It was inferior, a middle, and a superior nasal concha. Okay. And the bone above that is your sinus.
paranasal sinus,
Yeah, your frontal sinus. Uh-huh. Perfect. All right. So structures of the lungs. In the structures, you have the apex, which is your superior portion, your base, which is your inferior portion. That's the part that touches the diaphragm. The right lung in a human has three lobes: the superior, the middle, and inferior. Has a horizontal fissure, which divides the two divisions, and an oblique fissure, which divides the third division. The left lung has two lobes, a superior and inferior. It only has an oblique fissure, does not have the horizontal fissure, because there is no middle lobe. The left lung has a carotid notch, where the pericardial sac fits inside that left lung, because the heart leans towards the left side. So it leans toward the left lung, there's a cardiac notch in there where that precordial sac sits. Okay, so again, if you look at your lungs again, this is your right lung, middle lobe, superior lobe, inferior lobe. There's an oblique fissure, same on both sides, which divides your superior and your inferior. And there's a horizontal fissure, which divides out the middle lobe. So only the right lung has a horizontal fissure, the left one does not. Okay, with the left lung, here's your horizontal fissure, your oblique fissure, I'm sorry, there's a horizontal fissure. Superior lobe, inferior lobe. This is the cardiac notch. That's where your precordial sac sits. That's where your heart sits. Remember, your heart leans towards the left side when it's in the body. Okay, so the right lung has a middle lobe and a horizontal fissure. The left lung has a cardiac notch. That makes them unique. The lung surface. Okay, there's a costal surface, there's a mediastinal surface, and a diaphragmatic surface. Costal surface is your ribs, mediastinal is between the apices, and the diaphragmatic is at the base. Okay. So here's your apex right here. Okay, there's the hilum. There's the base, which is your diaphragmatic surface. And this is your costal surface, your ribs. And this surface here is your mediastinal surface along the side where the heart's going to sit. Okay. And this shows your costal surface, your ribs, and this shows the diaphragmatic surface or the diaphragm, just like the picture we just showed before. Okay. The pulmonary bronchi. So your primary bronchi at multiple times. Once you're inside the lungs, that's your extrapulmonary bronchi while inside the lungs, intrapulmonary bronchi once they enter into it. So your bronchi start to branch. You got extrapulmonary and intrapulmonary as they go farther inside. Each primary bronchus divides to form a secondary bronchi, then a tertiary bronchi. Each tertiary bronchi goes on to specific lung areas called a bronchopulmonary segment. So you go from your primary bronchi, your division from your trachea. Those divide to secondary, those divide to tertiary, and those further divide into bronchopulmonary segments, different areas of the lung. Okay. So again, here's your primary bronchus, and it divides into secondary bronchus. The secondary bronchi divides into tertiary bronchus. The tertiary bronchus divides into bronchioles. They go into all these different sections of the lungs. So branches of the right primary bronchus divides into 3 secondary bronchi, the superior, middle, and inferior lobular branches, because there's 3 lobes in the right lung. Okay. So here's your superior lobular bronchus, your middle lobular bronchus, and your inferior lobular bronchus. Okay. On the left side, you're just gonna have your superior and your inferior. Okay. There is no middle lobular bronchus. Same picture we had before. You see your respiratory epithelium, and you see your sheath-shaped cartilaginous rings with the trachealis muscle in the posterior section of it, in the back. Again, the left primary bronchus only divides into 2 secondary bronchi because there's only 2 lobes, the superior and the inferior. So here's your superior lobe and your inferior lobe. Again, the middle lobular bronchus only occurs on the right side. Sorry. Your right lung has 3 lobes in humans. Your secondary bronchi, okay, they form, like I said, they form the tertiary bronchi. Your right lung has 10 tertiary bronchi. Your left lung has 9 tertiary bronchi. So it goes to 10 pulmonary areas. The left lung goes to 9 bronchopulmonary segments or areas. Okay, and that's how they divide. You can see the extra division here because of this middle lobe. You have another section where it can innervate, where the other ones don't. Okay. This is color-coded to show you the different areas where each bronchiole feeds into those different bronchopulmonary segments. Okay. This is a healthy lung. This is a, you want to guess? This is a smoker's lung.
That's what I was going to say.
Was that?
That's what I was going to say.
Yep. Absolutely correct. You can see how flexible this is, how elastic it is, healthy it looks. This is all charred. And the heat of a cigarette just destroys epithelium. Okay, the lung cannot expand anymore. So you get COPD, you get other diseases. Okay, because the lung can't expand. You can't catch your breath a lot of times when the lungs don't do that because they're basically charred. We had a patient who smoked and in the mouth had all these little red dots in the roof of his mouth. And I had no idea what was causing it. And he finally said he did what's called reverse smoking. I had never heard of that. I've heard a lot of things in 30-something years of doing dentistry, but I've never heard of reverse smoking. That's when you smoke the lit end of the cigarette. You reverse the cigarette and smoke it backwards.
Why?
That was my question.
What does that make?
That's exactly what I said. I looked at it and said, why? You get more nicotine and you get a greater feeling faster, was his explanation. But the whole roof of his mouth was completely charred. And all these little, what's called red petechiae. It had all these little red dots around the roof of his mouth, just full of them. I couldn't figure it out, but he said he did reverse smoking.
So
And then I had to look it up. And
cigarettes.
what's that?
Just buy unfiltered cigarettes.
I probably reverses those too. I know, but I just didn't get it. That it's going to really destroy things really fast.
Is there a reason why the heart on the right side is larger than the one on the left? Is it because of smoking, or is it just because this person was potentially obese?
The
It
heart,
looks like the lung is smaller to me.
Okay, that makes sense.
they've shrunken. They're charred. When you burn meat, it gets smaller, right?
Okay.
On the barbecue, when you burn it, it gets smaller, charred. It gets dehydrated. There's less fluid. There's less flexibility. So when you burn it, it gets smaller. So the heart looks larger because the lungs are smaller. Plus, when you can't get oxygen from the lungs anymore, the heart has to work harder. So you get you get your you get left ventricular failure, or right ventricular becomes hypertrophy. So your heart becomes larger because it has to pump harder. Okay? So your heart actually expands. Your heart becomes large, especially the right ventricle. And you get right ventricular failure because it gets so large and so strong, the walls of the heart can't support it. and it fails. But you're right, the heart gets larger because it has to pump harder and stronger to get the same amount of oxygen it used to get. Okay, makes sense? Makes sense?
Yes. Yes.
Perfect. Again, look at the difference. When you hook up to a pulmonary machine, you can see these lungs inflate here. These are all healthy tissue. Okay, and this is a smoker's lung. You can see the difference. It's not going to expand anymore. Okay, you're not going to get the same amount of oxygen as you normally could. And you get all kinds of abscesses like this right here. You get all kinds of good cysts and abscesses, all that good stuff. All right. How much time do we have on this one? Do you want to take a 10-minute break? Or you want to just keep going on? How many do we have left? About 20 slides left. So 10-minute break or keep pushing through?
We really have 25 slides left. I would say keep going through, but I want to speak for
Yeah.
everyone.
Going through.
Finish.
Yeah, I think we should keep going.
Okay, you got it. I can keep talking, trust me. I can talk a long time. All right, we'll finish this up, then we'll call it early. Go get done early. So bronchioles, remember you have the primary bronchus, the secondary bronchi, the tertiary bronchi, then the bronchioles. They're just the smaller of the bronchi, the smaller the tubes. They got down to about 0.3 to 0.5 millimeters. Okay, they're self-supporting and do not require the cartilaginous plates. They stay open on their own. They're smaller, so don't have to have that much force around them. So they do not have cartilage plates. There's smooth muscle for bronchodilation, and bronchoconstriction. Remember the sympathetic system. The sympathetic system is your fight or flight. That's going to have bronchodilation. The smooth lung can relax and their lungs become bigger, more air can get in. Okay, the parasympathetic system are going to be bronchoconstriction. The smooth lungs can constrict and the bronchioles are going to get smaller because you need less oxygen when you're just relaxing. Again, your fight or flight response and your parasympathetic response. So the bronchioles terminate within the clusters of what's called alveolar sacs. That is where air exchange occurs. That's the part that's damaged in smokers or lung disease. Okay, you have these alveolar sacs. This is where the end of the bronchioles feed into these, and it's these little sacs that form all these little semicircles around this area where the air comes in, so gas exchange can occur between carbon dioxide and oxygen. You get alveolar ducts feed into the alveoli. Every lung has about 150 million alveoli. Okay, you get an extensive network of capillaries surrounding each alveoli because that's where exchange occurs. You have a tremendous amount of blood flow around each of those alveoli. Okay, the capillaries drop off carbon dioxide and pick up oxygen. So elastic tissue surrounds every alveolus, each individual alveoli. It maintains the shape and position of each alveolus during inhalation and exhalation. So you have that elastic tissue. Now, when you have that smoking lung, that elasticity is gone. Okay, so that shape cannot go in and out anymore. So what happens is all these little surface areas like that, they start to flatten out. Okay, you start to flatten out, you have less surface area, less air exchange, COPD, all the things that accompany it. Okay, so these are your alveoli, all these little balls, little sacs are here. And this is all your blood capillaries that surround it. Okay, that's where all the gas exchange occurs. Okay, and you can see the little alveolar sacs, these little circles here. Like I said, they're elastic, so they hold their shape. When you destroy that elasticity, they flatten out. No more surface area. Because your surface area increases as you have all these little sacs, right? You flatten it out, there's no more surface area. So no more air exchange, leads to COPD and other diseases. But a tremendous capillary beds around each of the alveoli for gas exchange to occur. Okay, so the cells associated with the alveoli, the lining consists of a single layer of squamous cells. Squamous means flat, squished, right? Okay, a single layer is simple squamous epithelium. Why is it a single layer?
So the air can, I don't know.
You're right, so air can exchange. It's a single layer, so you have your bloodstream here, and you have your air here, a single layer of cells. So oxygen can go in, CO2 can go out. very easily. It's just a single layer. You don't need any, there's no abrasion there. There's no trauma to that area. So nothing has to be thick. You don't need the stratified layers. Okay. You have a single, which is simple squamous layer, easy gas exchange because there's no trauma to that area. Okay. Those are called what's called type 1 pneumocytes. Those are those cells. Type 2 pneumocytes are also scattered through there. Type 2 pneumocytes secrete surfactant. Surfactant is extremely important. Surfactant lines the inside of the lungs. And what happens when you breathe out, okay, your lungs don't collapse and stick to each other. Surfactant keeps those bronchioles, those alveolar ducts open. Okay, premature babies, okay, when they're born preemies, they lack surfactant. That's why they go on respirators. They can't open their lungs back up again. Think of it as a balloon. If you're blowing up a balloon, you let that balloon collapse completely. It takes a lot of energy to push that back open again, right? Okay. If you have that balloon, just let air out and in, and don't collapse it completely. It's very simple to do. Okay. So surfactant coats the lung tissue in the alveolar area and prevents them from collapsing during exhalation. So you don't have to expand all that force again. Okay. A lot of times when preemies are born, the amount of force it takes of those lungs to actually blow their lungs out. You have to be very careful. It's extremely dangerous and it's very hard to do. That's what they try to deliver after the baby starts to produce surfactant. Okay, surfactant is a reason that you watch a premature baby's chest expand really rapidly and then collapse, expand and collapse on a respirator. Okay, they're forcing air into that lungs to open those tubes back up. Okay, which takes a lot of force. Once it collapses, like that initial puffing on a balloon, get that initial opening. So surfactant is produced and causes those and stops those alveolar ducts from collapsing upon themselves. And that's surfactant. Okay, it prevents alveolar collapse.
Is that shot they give to mature the lungs faster whenever you are in a high-risk pregnancy with the potential of going early? Is that what that does? Is helps create the surfactant, the steroid? I can't remember what it's called, but
Yeah, I know what you're talking about. I'm drawing a blank on the drug's name. It helps produce surfactant and mature the tissues earlier. So when you have a premature birth, that surfactant is going to be produced a little bit earlier. Yes, because you want that produced. Without that, it's very dangerous because the force, a lot of times the force you need to open those lungs back up is enough to actually blow those lungs apart. That's why during CPR, what do you do on an infant when you blow in their mouth? 2 fingers and just puff. You fill your cheeks up and you puff. You don't blow your air into that like you do on an adult because those lungs can't handle it. Even on a respirator, they have to be very careful because those lungs, you take so much force to open them, it's enough to actually destroy the lung tissue. So that's why surfactant is real important. That's why they do those injections when they know it's going to be a premature birth to help speed that production along and mature that lung tissue. Okay. But yes, surfactant is extremely important. And you will see that on every nursing exam you take, I guarantee you. You have to know what surfactant does. And it prevents the alveolar ducts and the alveoli from collapsing on exhalation. So it keeps them open so they can breathe, just think of a balloon, just opening up a little bit more in, a little bit more in, as long as it doesn't collapse. Once that balloon collapses, it takes a lot of force to blow it back up again. Okay. And you also have alveolar macrophages in there. Macrophages eat other things, phagocytes, part of material, any infection, bacteria, viruses, they destroy it, they get into the lungs. Okay. Again, here's your alveolar sacs and your alveolus. Okay, and this is the extensive capillary system that surrounds your entire alveolar system. A lot of blood supply, because the more blood supply, the more oxygen you get into your body. It's just that simple. Okay, so you have a huge amount of capillary network there. Okay, and the green ones you can see here, those are your lymphatic systems. Your lymphatic system, because along with air is not sterile. So you have your lymphatic system that runs right along with it. Here's a light microscope, your alveolar sac and your alveoli. Okay, and then your alveolar duct that conducts the air into the alveolar sacs. Okay, so your pulmonary arteries, Okay, transport carbon dioxide to the alveolar capillaries. Okay, remember pulmonary arteries. Do pulmonary arteries transmit oxygenated or deoxygenated blood?
Deoxygenated.
Deoxygenated. Perfect. Okay, so give you carbon dioxide into the alveolar capillaries. Carbon dioxide leave the capillaries and enter your alveolar sacs. Oxygen leaves the alveolar sacs and enters into the capillaries, and then goes to your pulmonary veins. The pulmonary veins are now oxygenated. They've gotten rid of the carbon dioxide, absorb the oxygen, and they go back into what part of the heart? The pulmonary
Left
vein,
atrium.
the left atrium. Perfect. The left atrium, the left ventricle, and it pumps the rest of the body. Okay. So here's why you have single, simple squamous epithelium. This is your red blood cell. Okay, this is surfactant. It lines the alveolar duct. Okay, your endothelium here, your basal lamina and the nuclei, and this can exchange air and carbon dioxide very easily through one layer of cells. Okay. So the right and left pleural cavities are separated by what's called the mediastinum. Okay, each lung is lined by a serous membrane. Remember, it's 2 layers. Take a balloon, take your fist, push it through the balloon. There's 2 layers around your fist, right? There's a layer that's actually touching your fist, and there's a layer that's to the air. There's 2 layers of that balloon. Those are 2 layers of your serous membrane. The visceral pleura, okay, is the outer surface. The parietal pleura is the inside lining of your thoracic wall. So your visceral pleura, okay, is what's touching the lungs. Your parietal touches the outside thoracic wall. Those are your 2 layers. The space in between them is your pleural cavity. Have you ever worked in an emergency room and had a patient come with pleurisy? Pleurisy is, you will notice you will notice them right away, because they will come into your emergency room and they will not want to breathe. Their breaths will be very shallow and they don't want to breathe. It's an infection in between the visceral pleura and the parietal pleura. They stick. So when you breathe and expand, it tears at the visceral pleura and the parietal pleura as it expands. It tears that pleura apart every breath you take. Extremely painful. Okay, it's an infection in between the 2 pleural layers. Okay, it's right in between this in the pleural cavity, and they stick together and extend. So every time you breathe, extreme pain as you rip apart your tissues. So they really short breaths. They don't breathe deep, and you get right away. You know patient has pleurisy. The pleural cavity between the visceral and parietal membranes consists of the pleural fluid. If the infection gets in there and reduces that fluid, they start to stick. This reduces friction when the lungs move in inhalation and exhalation between the 2 surfaces. And pleurisy, okay? Again, with the membranes produce too much pleural fluid, or the membranes adhere to the thoracic wall, resulting in pain upon inhalation and exhalation. It actually rips the tissue off the wall. Okay, it's been forced up there. Extremely painful. Like I said, patients will come in and they do not want to breathe. Very, very carefully breathe, very shallow, very short breaths. They do not want to expand their lungs. Okay, so here's your visceral pleura, and here's your parietal pleura. Visceral pleura is one lining the lungs. This is your pleural cavity right here. So if too much pressure builds up in there, it forces that parietal pleura into the thoracic wall. So every time you expand, it rips it off of that wall and causes extreme pain. But here's a good picture right here. Here's your pleural cavity. This is your parietal pleura and your visceral pleura. Your parietal cavity is in between, and it fills with fluid to keep it flowing naturally and less friction. Muscles that are involved in primary ventilation is your diaphragm. The main one is your diaphragm. As the diaphragm contracts, the thoracic cavity increases in size. You get a decrease in pressure, air flows in. That's how it works. That's why at higher elevations, you have less pressure. Why you can't breathe as well. To get used to the air, you have less pressure, so less air flows in under the same conditions. You have external intercostals and internal intercostals, muscles between the ribs. They also help in inspiration and expiration. So the diaphragm contracts, causes inhalation, lower increases thoracic cavity. Relaxes the diaphragm is exhalation. Okay. The external intercostals elevate the ribs to aid in inhalation. The internal intercostals depress the ribs to aid in exhalation. So external intercostals help with inhalation. Internal intercostals help with exhalation by elevating or depressing the ribs to help control the size of the thoracic cavity, to work with the diaphragm. So your primary muscles, okay, these are your external intercostals and your internal intercostals. Okay, see where they're located. These depress the ribs. Those increase the ribs. Not depress, what's the word I'm looking for? Elevate, sorry, elevate the ribs, okay? The internal muscles elevate the ribs, pull these up. These pull the ribs down and help aid with the air coming in and out with the diaphragm. Okay, and that's what it looks like. So ribs and sternum elevate when the diaphragm contracts. Okay, so you get inhalation. Inhalation is your active process, that's your force, okay? It's involved the diaphragm and external intercostal muscles. Okay, you see how it forces this area to increase and air will flow in. When this area decreases, air is pushed back out. So respiratory movements can be cut in two ways when you're in a medical office. You got eupnea and hyperpnea. Eupnea, okay? Eupnea is what we call quiet breathing. You can move diaphragmatic breathing or costal breathing. During pregnancy, due to the uterus pushing upward on the diaphragm, women typically use costal breathing. Okay, but from their rib cage, because the diaphragm can't move that much because of the uterus pushing on it. Hyperpnea is force breathing. Okay, you use accessory muscles to increase the amount of breathing. Okay. So prior to birth, the pulmonary arterial resistance is high, okay, because blood is not flowing through them. So the resistance is going to be high. Your pulmonary vessels are collapsed. We're not using them. Remember, there's the ductus arteriosus, the shunt between the ventricles, okay, that allow you to go from the right ventricle to the left ventricle, and from the aortic arch, and from the aortic arch from the left ventricle into the aortic arch. So there's two openings to prevent the blood from going to the lungs. Okay, so that your rib cage is compressed because it's not being expanded. So your lungs and passageway contain no air, but they contain a small amount of fluid. So that's prior to birth. You have fluid around there. The rib cage is compressed. There's high resistance in the pulmonary arteries because they're collapsed. They're not functioning. Right? At birth, air enters and forces the fluid out. Okay, you get the closure of the femoral valley between the ventricles and the closure of ductus arteriosus between the pulmonary trunk and the left ventricle, the aortic arch. It allows you to bypass. Both these allow you to bypass the lungs. This between the ventricles, this between the pulmonary trunk and the aortic arch. So those two allow you to close off the lungs. Once air comes in there, it forces those closed, both those openings, which forces the baby to breathe. Okay. There's three pairs of nuclei in the pons and the medulla oblongata that regulate this respiratory muscles. You get the respiratory rhythmic center that starts to set the respiratory pace, roughly 12 breaths per minute. The apnoistic center adjusts the pace. The pneumotaxic centers also adjust the respiratory pace. Okay. Those two centers adjust the respiratory rhythm here, apnoistic center and the pneumotaxic center. Okay, so there's your pons. Here's your pneumotaxic center and your apnoistic center. Okay, and it controls your respiratory rhythm centers. It controls how often you take a breath. Okay, there's three different reflexes involved. There's mechanoreflexes, there's chemoreceptors, and there's protective reflexes. The mechanoreflectors respond to changes in lung volume or changes in blood pressure. It's a mechanical response. Okay, it's how much the lungs are expanding. If the lungs are overexpanding, they prevent it from they prevent that overexpansion. So those are mechanoreceptors. Chemical receptors, chemoreceptors, I'm sorry. Response to change in partial pressures of carbon dioxide and oxygen. They respond to changes in your pH, the different chemicals that make it up. Okay. The hydrogen ion concentration of your blood, how acidic it is. All right. And the protective reflexes respond to physical injuries or irritation of how you breathe. Okay. As you age, after 21, things go downhill. Noteworthy changes. Elastic tissue becomes to deteriorate. Your lungs become less elastic. It's harder to breathe. Lungs cannot expand or constrict as much as they used to. The elasticity begins to go out. Movement of the ribs are restricted due to arthritis. That's when your prime muscles to help with the diaphragm. The ribs can't move as much for exhalation and inhalation because of arthritis. Emphysema starts to hinder breathing. With age, roughly 1 square foot of your respiratory membrane is lost each year after age 30. So after age 30, you lose about 1 square foot of that respiratory membrane, which square foot is 1 foot by 1 foot by 1 foot, 12 inches each way. That's a big volume to lose every year after age 30.